Introduce myself. I think some of you know me already. I'm Kiran Traga. I'm one of the new surgical oncologists here and came as the division chief of surgical oncology. So it's really nice to meet all of you. And it is also my privilege to introduce one of us who's going to be speaking today. It's my privilege to introduce Dr. Courtney Gibson. Dr. Gibson is an endocrine surgeon and associate professor of surgery at the Yale School of Medicine. Courtney is an accomplished clinical surgeon who takes care of diseases of the thyroid, parathyroid, and the adrenal gland, including minimally invasive laparoscopic, retroperitoneoscopic surgeries, and is also the fellowship director of our endocrine surgery program fellowship, one of the premier fellowships in the country. Courtney's research interests include outcomes after minimally invasive surgery, outpatient thyroidectomies, and parathyroidectomies, so newer sort of ways of thinking about how we take care of these patients, intraoperative laryngeal nerve monitoring, and endocrine oncology. Courtney obtained her MD from VCU and was a postdoctoral research fellow at CHOP in Philadelphia and completed her training in general surgery at St. Barnabas and endocrine surgery at Scott & White. So it's my privilege to introduce Dr. Gibson.
All right. Good afternoon, everybody. And I thank you for the opportunity to kind of present an important topic. I think it's some cutting edge work that's being done in the management of thyroid disease. And so we're excited to kind of be implementing this in the near future here at Yale. So today's talk is going to be on a discussion about radiofrequency ablation of thyroid nodules, what current indications are, and where are we headed in the future. I have no disclosures. So what we're going to do is define radiofrequency ablation, the technique, what exactly it entails. And we'll discuss some of the current guidelines, which are largely international, but there's been a concerted effort to kind of get consensus on management and treatment guidelines for this technique. We're going to go into some more specifics about the specific technique of how to perform thyroid RFA ablation of thyroid nodules. And then briefly, we'll go over some other non-surgical ablative interventions that can be used and see how they compare to radiofrequency ablation. And then lastly, we'll discuss some future potential indications in the treatment of thyroid disease and particularly thyroid cancer. So first, what exactly is radiofrequency ablation? It's not a new technique. It's just a newer indication for it in the management of thyroid disease. And so what it is it's a procedure in which part of a tumor or other dysfunctional tissue is ablated using the heat generated from medium frequency alternating current. The radiofrequency ablation destroys targeted tissue through a combination of frictional and conduction heat that's generated from high frequency alternating electrical current. And the oscillations are typically between 200 and 1200 kilohertz. Frictional heat is created when the RF waves pass through an electrode, and they then agitate tissue ions as they try to follow changes in the direction of the alternating current. The result is an increase in the temperature of the surrounding tissue within a few millimeters of the electrode tip, and then heat conduction from the ablated area yields a slower additional form of thermal damage to the target tissue, and eventually tissue that is further away from the electrode. So immediate coagulation necrosis is achieved by friction heat generated in the vicinity of the electrode. However, the tumor tissue remote to the electrode is also ablated, but at a much slower rate due to conductive heat. Friction heat is more powerful than conduction heat. And although conduction heat near blood vessels is more affected by a heat sink effect, whereby the heat dissipates pretty quickly because of the flow of blood through those vessels, the ablation range of the friction heat is very narrow and focused, and is limited to just a few millimeters beyond the tip of the electrode. So therefore, the majority of the nodule is ablated by conduction heat. This technique has been used for decades, at least 20 years or longer, in the non-surgical treatment of various solid organ tumors, but has only recently been applied to tumors of the thyroid gland, and with the most robust experience has been occurring in South Korea. For this approach, typically there's a transisthmic approach that's used. And so in this approach, the entire length of the electrode can be visualized. There's minimal exposure of the heat tip to critical structures, such as the recurrent laryngeal nerve or the esophagus in the left cervical neck. And additionally, because the electrode passes through an ample amount of thyroid tissue. This prevents a change in position of the electrode as a patient speaks or swallows during the procedure. And it also prevents the leakage of ablated thyroid liquefied tissue. So here you see through the transisthmic approach, the electrode is being introduced through the isthmus and headed over, in this case, to the right thyroid lobe. And the needle is inserted a few millimeters from the border of that thyroid nodule, because again, the heat generated is going to extend beyond the electrode tip. And then successively, in matters of millimeters of distance, the electrode tip is moved back to ablate the area, and then it continues on to get the majority of the nodule ablated. In this manner, you avoid this, what we call the triangle of danger. So this is where the recurrent laryngeal nerve is located in the tracheoesophageal groove. And on the left side, this depiction is the cervical esophagus. It's very mobile, and so it can be on the left or right side, and it's important to know your anatomic structures, but typically it lies in the left cervical neck. In addition to the transisthmic approach, there's a technique called the moving shot technique, which I kind of started to describe. And in this technique, the thyroid nodule is conceptually divided into multiple small ablation units. So these units are smaller at the periphery and then get larger as you get to more centralized areas of that nodule. The RFA procedure is then performed unit by unit, moving the electrode tip from the most distal or deep location to a more superficial location. And although this technique can successfully prevent nodule regrowth in a majority of thyroid nodules, there can be some undertreated portions, particularly if you are concerned about surrounding critical structures. So you want to be a little bit away from the very border, the very margin of that thyroid nodule. So in cases of recurrence, it's usually marginal regrowth, but oftentimes it's not significant enough to cause recurrence of symptoms in patients. Undertreated portions of the nodule, so near that triangle of doom, can occur, or in cases where the nodules are larger, so larger than like 20 millimeters, and sometimes they require more than one treatment. So let's see, hopefully this video will show here. So this is just showing the actual moving shot technique. In this approach, the transisthmic approach and moving shot technique are used in combination, and they're recommended as a standard procedure. But it's important to note that the best approach is the one in which the operator is most comfortable with. As a thyroid surgeon and in my training, we learned to do fine needle aspirations through a different approach, not going through the isthmus, but facing the patient, so that the left side of that patient is what you see on the ultrasound screen. So whatever you're most comfortable in way in performing your ultrasound, and your fine needle biopsy is typically the way that you're going to perform the RFA ablation. The electrode is inserted via the isthmus in the midline to lateral direction to approach the target nodule through either the right or left thyroid lobe. And then the ablation proceeds from the deepest and most remote portion of the to the most superficial portion of the nodule by slowly pulling back on the electrode tip. And this is known as a moving shot technique. So during ablation, echogenic bubbles are generated from the active tip, and the location of the electrode should always be continuously monitored by real-time ultrasound guidance during the procedure to prevent possible thermal damage to other important structures. So more recently, the marginal venous ablation technique has been added on. And so most of these nodules have a feeding vessel that is along the periphery of the nodule, right? And so we found that a lot of the recurrences occur because there's not been an appropriate amount of devascularization of that thyroid nodule. So by ablating the feeding vessel, you decrease the risk of recurrence. And so in a similar way to the actual ablation of the thyroid nodule, the marginal vein is punctured by the electrode tip and ablated. Let's see if this shows here. And so what you'll see is that air bubbles start to fill that marginal vein of the nodule. And initially the air bubbles flow pretty rapidly along the marginal vein as long as there's a remaining venous flow. But over time, the venous flow gradually decreases and eventually stops completely. And so the air bubbles stay inside the veins, and that indicates complete ablation of that vein. The tip of the electrode is located at the main vessel that's feeding the nodule in the hypoechoic area over this way. And then it's ablated for a few seconds, and during ablation, echogenic bubbles are generated from the active tip. So why thyroid RFA? So in general, thyroid nodules are a prevalent clinical problem. So up to 70% of the population has one or more nodules, thyroid nodules detected on ultrasound. And although most benign nodules can be safely observed, there's a good portion of the nodules that require definitive management for various reasons. Significant increase in size, continued growth of a nodule, compressive symptoms, some cosmetic concerns, or autonomously functioning nodules that lead to hyperthyroidism. So surgical resection has long been the mainstay of treatment for these benign but problematic nodules. And in fact, of approximately 140 to 170,000 thyroid procedures performed annually in the United States, 2/3 of them are for benign disease. And although they're associated with excellent outcomes and low complications in experienced hands, thyroidectomy still carries a significant risk of complications, although it's low, most importantly including injury to the recurrent or superior laryngeal nerve, or in the cases of total thyroidectomy, the requirement of lifelong thyroid hormone supplementation. Even in thyroid lobectomy, we as thyroid surgeons often quote a potential risk of lifelong thyroid hormone supplementation of about 15% or so, but the true reported incidence is probably more closer to 30%. So that's not insignificant, and a lot of our colleagues in medical endocrinology can attest to that. And so even after a lobectomy, those patients are in need of some form of thyroid hormone replacement, which is not insignificant. RFA ablation pretty much eliminates that risk when performed properly. There's no requirement for thyroid hormone as long as the patients have been properly vetted for the procedure. So in the past couple of years, there's been a great enthusiasm for RFA in the United States and its potential role in the management of benign and in some cases for potentially malignant lesions of the thyroid gland. So the first RFA ablation of a thyroid nodule actually occurred back in 2002 in Seoul, South Korea. And shortly after that, the first case series was reported by that group of researchers in 2006. After that, the Korean Society of Thyroid Radiology, which is an organization of thyroid radiologists primarily involved in the diagnosis and management of thyroid nodules, they proposed some preliminary recommendations for thyroid RFA. In 2009, and this primarily focused on indications and efficacy. And since that time, their guidelines have been revised first in 2012 and then again in 2017, based on newer evidence obtained from some clinical studies of RFA in patients with both benign and malignant thyroid disease. Shortly after that, similar guidelines were developed in Europe in 2020. Right. So indications for thyroid RFA are largely for benign but symptomatic disease. So, the majority of thyroid nodules are benign in general. Some nodules can cause some cosmetic problems or pressure symptoms that I described earlier. Pain, dysphagia, foreign body sensation, or some can be autonomously functioning. And in these cases, radiofrequency ablation is a good technique that can improve the clinical problem by reducing the nodule size. In management and assessment of these patients, a symptom score is typically created by using a visual analog scale, and a cosmetic score is measured by the treating physician with a score ranging between 1 and 4, 1 being no palpable mass appreciated and 4 being a readily detectable cosmetic concern. So prior to performing thyroid RFA, a thyroid nodule should be confirmed as benign on at least 2 ultrasound-guided FNA biopsies or 1 core needle biopsy. One caveat to that is that if the characteristics on ultrasound clearly look like a benign nodule, you can get by with just 1 FNA biopsy showing benign disease. The reason for the second biopsy has largely been because in cases of larger thyroid nodules, greater than 3 centimeters, 3 or 4 centimeters, there's about a 10% risk of a false negative FNA biopsy. So we always like to have a second biopsy to confirm that we're truly dealing with benign disease. However, in the area of molecular testing, there's now opportunity to kind of downgrade nodules even when they have an indeterminate look on imaging, and those patients can go on to have RFA treatment as an option. Ultrasound examination is important to characterize the nodules or recurrent cancers in some cases, and to evaluate the surrounding critical anatomic structures. So you want to see the nodule in question, where is it proximity to the critical structures that we mentioned, the recurrent laryngeal nerve or the esophagus, and also how close it is to the surface of the actual thyroid capsule in the skin. Some people have very bulky necks and you have more leeway, where others have very thin necks and there's not a lot of tissue separating the actual skin area from the thyroid lesion. That's important when you're using a heated probe. Laboratory tests are important and usually include a CBC, blood coagulation battery, and some thyroid function testing. So on ultrasound, some benign features are typical hyperechogenicity, so looking a little bit more gray than the surrounding structure, hypovascularity or a lack of vascularity to the thyroid nodule, macrocalcification, so larger than 3 millimeters, and smooth borders. And if the nodules have these characteristics, then one FNA biopsy is reasonable. Whereas some concerning features on thyroid ultrasound would be the opposite: hypoechogenicity, hypervascularity, microcalcifications, or irregular borders. After RFA, for non-functioning benign thyroid nodules, again, you want to look at the clinical, laboratory, and imaging checklist. RFA should be terminated when the entire area of the nodule becomes a transient hyperechoic zone of gray on grayscale ultrasound. And then grayscale ultrasound and color Doppler should be used to identify any remaining vascularity to the lesion so that you can continue to perform RFA to ensure the best outcome. After RFA, the nodule-related symptom score, again, neck pain, dysphagia, foreign body sensation is assessed, reported by the patient, and the cosmetic score reported by the physician to evaluate the effectiveness of that RFA therapy. Following RFA of autonomously functioning thyroid nodules, thyroid function should be monitored by measurement of the TSH, T3, and free T4 at each follow-up. And based on TSH changes, anti-thyroid medication can be reduced or stopped. The therapeutic response of the patient depends on their initial drug dosage required and is typically classified into 3 categories for autonomously functioning thyroid nodules. So a complete response means that after this treatment, usually 2 to 4 months afterwards, that patient is no longer on any anti-thyroid medication. A partial response is that that patient still requires some anti-thyroid medication, but it's significantly reduced. And then no response is the patient is still deemed hyperthyroid and requires medication. And in those cases, they get pushed on to a further intervention, whether that be a second RFA treatment or more definitive treatment with radioactive iodine therapy or surgery. On the ultrasound examination post procedure, you want to look for changes in size of the nodule, the volume of the nodule, intranodular vascularity, and echogenicity. And if the thyroid function symptoms are incompletely resolved, again, repeat RFA or another treatment such as medication or surgery may be required. You also want to look at the thyroid function of non-functioning thyroid nodules as well too, because one of the great benefits that is being reported is that these patients do not end up being hypothyroid after these interventions, unlike thyroid lobectomy, where they may end up hypothyroid. So if a patient has normal thyroid function pre-RFA procedure, they should also have preservation of that euthyroid state afterwards. So it's important to check a TSH. And along those lines too, if there's any concern that that patient may have autoimmune disease, that should be further investigated pre-procedure with check for thyroglobulin or antibody levels to see if that patient actually has autoimmune disease of the thyroid gland, because they're at a higher risk of requiring thyroid hormone after any intervention, including surgery and RFA. Let's see, I think I may have skipped. Okay, here we go. So in terms of the management of cystic thyroid nodules or predominantly cystic thyroid nodules, these nodules are amenable to ethanol ablation, and it's been proven to be extremely effective in the treatment of cystic thyroid nodules. Beck et al. Back in 2015 carried out a single-blind randomized trial to compare the efficacy of RFA versus ethanol ablation in the treatment of these cystic or primarily cystic nodules. And inclusion criteria included patients with thyroid nodules that were at least 50% and no more than 90% cystic who had compressive symptoms from these nodules. Benign cytology was confirmed with FNA biopsy or core needle biopsy, and normal thyroid function was demonstrated biochemically. The mean volume reduction reported was around 87% for RFA and 82% for ethanol ablation, indicating no significant difference between the two techniques. And regarding the secondary outcomes, therapeutic success, mean symptom, and cosmetic scores also showed no difference. There also were no major complications in either group. And so these authors concluded that the therapeutic efficacy of RFA was not superior to that of ethanol ablation. And so that ethanol ablation might be more preferable as first-line treatment for cystic or primarily cystic thyroid nodules due to the ease of the technique and the lower cost of ethanol ablation. A prospective study out of Italy evaluated the safety and efficacy of RFA in the treatment of solid thyroid nodules. In this study, there were 84 patients who, with symptomatic and cytologically benign solid nodules, were randomly assigned to either a single RFA session for Group A or surveillance for Group B. And again, inclusion criteria was a solid thyroid nodule or predominantly solid, with meaning less than a 30% fluid component. Normal thyroid function, no evidence of autoimmune disease, and no previous thyroid gland treatment, surgery, or otherwise. 3 subgroups were formed according to the baseline volumes of the nodules. So a small nodule was considered to be a volume of less than 12 milliliters. A large nodule was considered to be greater than 30 milliliters in volume, and intermediate was in between those 2 parameters. And in the RFA group, the RFA was performed in a single session using the moving shot technique. The volume and local symptom changes were evaluated at 1 and 6 months after the procedure. So in Group A, the volume decreased from 24 milliliters to 9.5 at 6 months post-RFA. And the greatest volume reduction was found in the smaller nodules, those being 12 milliliters in volume. The pressure symptom score improved significantly only for the medium and large nodules, and that's largely because they were larger and large enough to cause compressive symptoms or more significant compressive symptoms in those patients, whereas the cosmetic score improved in all treated patients. In Group B, the surveillance group, the nodule volume remained unchanged, but the symptom score worsened at the 6-month time point evaluation. And in terms of any complications, there's only one patient who experienced vocal cord palsy due to a recurrent laryngeal nerve injury. So in terms of longer term efficacy of RFA treatment, results still remain favorable. DeAndrea and his group evaluated a cohort of 215 patients who underwent single session RFA for benign thyroid nodules and then followed them for at least 3 years post-procedure. And they found significant shrinkage of the nodules throughout the entire observational period. And in particular, the median volume observed over 6 months after the procedure was significantly lower than at baseline. Progressive volume reduction was also seen at the 1 and 2 year follow-up time points. And also compressive symptoms and cosmetic concerns improved after the RFA therapy. There was a significant reduction in compressive symptoms at 1 year post-procedure, and this remained stable at 5 years. And similarly, cosmesis was improved and remained stable over that same time period. No major complications occurred in the treatment group, and the authors concluded that reliable and durable shrinkage of the benign non-functioning thyroid nodules with improvement of subjective symptoms can be obtained with radiofrequency ablation. Now, functional thyroid nodules are a little bit more difficult to treat, whether it's surgery or medication or non-surgical interventions, but they can also be targeted with radiofrequency ablation. It should be noted, though, that resolution of hyperthyroidism is less predictable than after radioactive iodine therapy for hyperthyroidism or surgery. And so reported success rates of RFA are very variable, ranging from anywhere from 24 to 72%. Because the efficacy is associated with the nodule volume reduction of 80% or greater, RFA is best suited for patients with small nodules, so those that are 3 centimeters or less, and a single autonomously functioning thyroid nodule as opposed to toxic multinodular goiter or Graves' disease. Scintigraphy is also recommended to confirm the presence of an autonomously functioning nodule as opposed to Graves' disease or toxic multinodular goiter. T3 and T4 should be measured whenever the TSH falls outside of the normal range. So sometimes there's subclinical hyperthyroidism that can be picked up by measuring all 3 of those parameters. The prevalence of these autonomously functioning nodules varies according to the geographical area and the amount of iodine intake in that country. But in the general population, it's estimated that the prevalence ranges from 2.5% to 4.5%. And surgery and radioactive iodine therapy represent the standard of care for this condition. So far, the literature shows that RFA normalizes thyroid function in about half of these cases. So roughly 50% of patients who undergo RFA ablation of autonomously functioning thyroid nodules have resolution of the hyperthyroidism, and it goes up to 80% with smaller nodules, those less than 3 centimeters. This is associated with a significant nodule volume reduction after about 2 years of evaluation from the time of treatment, and it ranges from 68 to 84%. So RFA overall does not seem to perform quite as well as surgery for these particular type of nodules, but still can remain an option, particularly in patients who are not surgical candidates or who are a little bit reluctant to undergo surgery for hyperthyroidism. So briefly, I want to talk about a few other non-surgical alternatives to radiofrequency ablation of thyroid nodules. And there are about 3 or 4 that have been looked into. So as I mentioned earlier, percutaneous ethanol injection. So treatment options for symptomatic benign cysts include needle aspiration, minimally invasive techniques, or surgical resection. And with needle aspiration, the recurrence rates are very high, and that's because you never ablate the actual cells that are lining that cyst that are secreting the fluid. So patients get aspirated, and sometimes they have resolution of symptoms that last, for months, maybe even years or so. But more often than not, those symptoms recur fairly quickly, and then they're left with what to do with those recurrent symptoms. Do you subject them to surgery? Do they kind of just deal with the compressive symptoms? And this is where the role of RFA has kind of come into play, and also other interventions like ethanol injection. So a study at the Mayo Clinic evaluated the safety and efficacy of percutaneous ethanol injection for thyroid cysts, and they looked at about 20 patients who had cystic thyroid nodules. 8 of them had purely cystic nodules, and the other 12 had a complex cystic nodule where over 50% of the nodule was cystic. And at 2 years follow-up, a median of 2 years follow-up, almost 90% of patients were asymptomatic, and 70% had at least a 50% reduction in volume, and 50% reduction at 6 months after ablative procedures is considered an effective treatment. So in terms of safety, 4 patients had mild temporary side effects, and most of it was pain at the injection site or mild bleeding into the cyst. And so these researchers overall concluded that ethanol ablation was safe and effective for patients with symptomatic thyroid cysts, and is actually the preferred non-surgical treatment for the treatment of cystic thyroid nodules. So although ethanol ablation is very effective in treating cystic thyroid nodules, it's much less effective for solid nodules. And that's where laser ablation or other thermal ablative therapies kind of come into play. So laser ablation with Nd:YAG is a thermal ablation method that's better suited for treatment of solid thyroid nodules. The laser is actually an acronym for light amplified stimulated emission of radiation. It was first described by Pacella back in 2004. And the procedure involves inserting 2 to 3 spinal needles into a nodule under ultrasound guidance. This does not involve a moving shot technique. So once you have those needles injected, that is going to be the location of where they remain. And then laser fibers are then positioned through those needles to allow for the Nd:YAG power of 4 watts and between 15 to 2,000 joules per treatment. The ablation needle is typically placed within the thyroid nodule along its cradiocaudal axis, and then the fibers are exposed to a depth about 5 millimeters beyond the needle tip. And that kind of is shown here. So there's highly echogenic area that results from the tissue heating and vaporizing during the laser firing. And then you see on colored Doppler the images obtained from laser illumination. So after final ablation, laser marks are seen as anechoic spots representing cavitation caused by tissue vaporization, and then they're surrounded by a kind of a hyperechoic rim. A coagulation zone is demonstrated as this hypoechoic area separated by a rim of viable tissue. Papini and his group in a randomized study of 200 patients compared laser ablation and clinical observation in patients with benign thyroid nodules, and they demonstrated a significant and persistent reduction in the volume of the laser-treated nodules compared to controls. And this also was associated with improvement in the local symptoms with no change in thyroid function. So in this study, a single laser therapy session with 2 fibers induced a significant volume reduction greater than 50%, and the improvement of local symptoms in the vast majority of these solid nodules. After the treatment, the volume reduction was progressive until 12 months and remained stable out to 3 years. And there's only a small minority, less than 5% of patients that had a partial regrowth, usually around that marginal area. So the efficacy of radiofrequency ablation appears to be just slightly superior to that of laser ablation, and the adverse effects are somewhat fewer. So they're pretty comparable, but the slight but beneficial findings of RFA are thought to be attributable to the fact that we use a moving shot technique with RFA ablation. So there's more area of that nodule that actually can be ablated as opposed to just the lasers sitting in that same spot, the laser needles sitting in the same spot for the laser therapy. Microwave ablation is another thermal technique that's used. It's a newer one, and it relies on the generation of this electromagnetic field with wavelengths between 0.03 and 30 centimeters and a frequency between 900 and 2500 megahertz. And this causes oscillation of polarized ions, specifically water. This oscillation then creates friction and then increases the local field temperature. So because an electromagnetic field is used instead of an electrical current, the electrical conduction is not necessary. So the thermal spread is not as impeded by things like char or heat sink as with the RFA technique. A needle-like antenna similarly is used to propagate the current, and multiple antennae can be used together to cause an exponential increase in the amount of heating that occurs within the nodule. So microwave ablation offers the ability to deliver more thermal energy in a shorter time, and this results in a higher final tissue temperature. So this reduction in treatment time can be more valuable when you're treating larger tumors. But because the anatomy of the central neck is very compact, it's also possible that these factors represent some disadvantages. So rapid heating that is less responsive to heat sink can explain some complications described in some early series of microwave ablation of thyroid nodules. There's a lot more heat generated and it dissipates much more slowly than with the other techniques. The aim of a study by Wu was to define the effectiveness and safety of percutaneous microwave ablation for benign thyroid nodules after one session. So in this study, a total of 121 benign thyroid nodules in 100 patients who were euthyroid, they underwent microwave ablation at a single institution between 2014 and 2015. And this was performed with an internally cooled antenna under local anesthesia. The volume of the nodule, the cosmetic score, and symptom score were compared before and after the procedure, and the volume reduction rate was also calculated. Side effects and complications were recorded. And what we see is that there was a continuous decline in the volume reduction rate after microwave ablation, and the volume rates at 3, 6, 9, and 12 months were 57, 70, 77, and 85 respectively. The most current or recent technique that's being used is high intensity focused ultrasound. So this is a more unique non-invasive modality that uses sound waves as a carrier to target specific lesions of focus. High intensity ultrasound transfers sufficient energy to induce this coagulative necrosis through thermal and mechanical injury. And the thermal effect is achieved by the conversion of the energy generated by intense tissue vibration. And this vibration kind of turns into frictional heat. Absorption within a focal target area creates high temperatures locally, and then immediate cell death occurs once temperatures exceed 55 to 60 degrees Celsius. So at this temperature, water within the tissue vaporizes and microbubbles begin to form. And it's this microbubble expansion and then collapse that leads to mechanical damage and hemorrhage within nearby cells. So with this technique, it's an emerging treatment option for thyroid nodules, but a key component and challenge to this particular technique is the delivery of energy to a small area without causing significant damage to intervening and surrounding structures. So similar to microwave ablation, you have higher heat energy generated and a slower resolution of that heat, which can lead to higher complication rates. So although HIFU is a promising form of ablation in the short term, the medium to long-term outcomes following a single treatment are not well established. And to date, the only study that has reported on medium to long-term efficacy with this treatment was performed by Lang. And in that study, there was a total of 108 patients who underwent this HIFU treatment and were followed for 2 years. And at the 2-year follow-up time period, fewer than 2/3 of the patients had smaller volume than at the 12-month time point. And then an additional fifth of nodules actually had a small increase in volume compared to that 12-month time point. So as I mentioned earlier, the first reported treatment of thyroid nodules by the RFA technique occurred in South Korea back in 2002. And, although RFA techniques have been steadily gaining acceptance in the United States, in Europe and Asia for over 20 years now, the United States have been a little bit more slow to adopt these techniques. The fact that the FDA did not approve the use of RFA for soft tissue masses or thyroid nodules until February of 2018 probably contributed to this delay in the adoption process here in the United States, along with the pandemic also causing some delays in developing this practice. So although these advantages are well documented in international series, there's still a paucity of data from the United States experience. This will likely change over the next few months because several institutions in the United States are now publishing their outcomes from their early experience with RFA of thyroid nodules. So currently there are 13 established RFA programs in the United States. And over the next several months, at least 24 additional programs are expected to develop, which is going to greatly increase access to patients here who are interested in undergoing a less invasive procedure than surgery. So the first U.S. experience with thyroid RFA, it was a retrospective review of 14 patients out of the Mayo Clinic. And so these patients had solid thyroid nodules that were treated with a single RFA procedure from December 1st, 2013 through October of 2016. All patients either had declined surgery or were poor surgical candidates. The thyroid nodules were benign on fine needle aspiration. They were enlarging or causing compressive symptoms, and they were at least 3 centimeters in size. Thyroid nodule volume, compressive symptoms, and cosmetic concerns were evaluated, and the median volume reduction induced by the RFA technique was 44%, down from 24 milliliters all the way down to 14. Median follow-up was about 9 months, and maximum results were noted to be achieved at the 6-month time point. So these researchers found that RFA did not negatively impact thyroid function. And in fact, in the one patient who had subclinical hyperthyroidism due to a toxic adenoma, that patient had normalization of their thyroid function 4 months after the ablation procedure. So further, compressive symptoms resolved in 8 of 12 patients, or 67%, and improved in the other 4. And cosmetic concerns improved in all 12 patients. So the procedure had no sustained complications, and the authors concluded that RFA of benign large thyroid nodules performed similarly to reports internationally, which was encouraging. The next study occurred out of Columbia University by 2 experienced endocrine surgeons, Dr. Jennifer Kuo and Dr. James Lee. And they wrote on their experience of 16 patients since starting their RFA program back in 2019. So most of these patients had benign thyroid FNA biopsies and with compressive symptoms, but additionally, there were 2 patients who had toxic nodules and 1 patient with a recurrent metastatic thyroid cancer. So these authors reported that all patients tolerated the procedure well with just minimal procedural pain and no long-term complications. At 1 month follow-up, the mean volume reduction was 50%, over 50%. And additionally, both patients who had toxic nodules had 1 month follow-up and were found to be euthyroid. And all patients who had undergone 3-month follow-up also had normal TSH levels indicating euthyroid status in those patients as well. So again, the preliminary US data has been comparable to that experienced internationally. Next, there was a study to evaluate the safety and efficacy of RFA in patients who had indeterminate nodules. And so this was a retrospective single center study, and this was 53 patients who underwent RFA, a total of 58 thyroid nodules. The reduction in volume, cosmetic and symptomatic improvement, as well as the effect on thyroid function and complications were assessed. And once again, the median reduction volume was over 50%. It was 70% after a median follow-up of over 100 days, with significant symptomatic and cosmetic improvement in all cases. And compared to larger nodules, these authors noted that the smaller nodules had greater volume reduction and improved TSH in autonomously functioning thyroid nodules. And also there was no effect on the TSH levels in the non-toxic thyroid nodules. There were no major complications, importantly. There was 1 patient who had self-limited local bleeding and another had a transient voice change that resolved after 6 months. So again, these authors concluded that RFA is a safe and efficacious treatment option for both symptomatic, non-functioning and functioning thyroid nodules. And then lastly, more recently, there's been a study out of Tulane to look at indeterminate nodules, which are a vast majority of nodules that we see. So these nodules have either they're Bethesda type 3 or 4. So 178 patients who had either benign nodules, so Bethesda 2 or less, or indeterminate Bethesda 3 or 4 on FNA were included. And patients in the benign and indeterminate cohorts had similar thyroid nodule volume and reduction rates were 65 and 64%. So no significant differences between completely benign thyroid nodules and these indeterminate thyroid nodules. There were a total of 3 cases of dysphonia reported that resolved. And so this was the first study to really look at indeterminate, not clearly benign nodules, not clearly malignant nodules, but indeterminate thyroid nodules, and found that they're comparable to benign thyroid nodules in terms of the efficacy. So this was the first North American analysis comparing benign and indeterminate nodules and suggested that RFA is a promising modality for the management of indeterminate thyroid nodules. The most common indications for RFA still remains treatment of benign disease, both non-functional and autonomously functioning, but there's potential expansion of the indications for RFA that are being investigated. So currently, there's only 2 institutions here that are recruiting patients for clinical trials in the United States, evaluating the safety and efficacy of RFA for the treatment of low-risk, well-differentiated papillary thyroid cancers, and that's the Mayo Clinic in Columbia. And thus far, there's only 2 U.S. institutions that have used RFA to treat recurrent thyroid cancer, being Columbia and Oregon Health and Sciences University. So current knowledge of the efficacy of RFA for the treatment of thyroid cancer is still limited and largely comes from our international experience. Recently, NCCN guidelines from the indicate that RFA can be considered in the management of recurrent thyroid cancer, particularly if patients are a high kind of surgical risk. And in fact, RFA has actually been used for this specific indication in Southeast Asia and Europe. So back in 2014, Beck again looked at patients who had undergone RFA for local regional recurrent PTC. And the inclusion criteria were no evidence of metastasis beyond the neck, no more than 4 areas of tumor, confirmed recurrence by ultrasound-guided FNA, and thyroglobulin measurement on needle washout. So more than a 6-month follow-up period was needed, and surgery was not feasible or was refused by the patient. And so in this case, there were 61 recurrent tumors in a total of 39 patients, and the mean follow-up duration was about 26 months. These researchers found that tumor volume decreased significantly from 0.2 milliliters before ablation to 0.02 afterwards. And the overall complication rate was relatively low at under 8%. So these authors also concluded that RFA can effectively control local regional recurrent papillary thyroid cancer without life-threatening complications in select patients. And then in a follow-up study, the same group reviewed 29 patients who had undergone RFA for recurrent PTC, and they followed them for at least 5 years. They looked at the change in size on ultrasound and thyroglobulin levels at the 1-month follow-up, 3, 6, and 12 months, and then every 6 to 12 months after that 1-year time point. And so any complications identified during the follow-up period were also reported. The mean follow-up duration was 80 months, and tumor volume decreased significantly from 0.25 to 0.01 at the final evaluation. And so the mean volume reduction was over 99%. 42 of the 46 treated tumors actually had completely disappeared by the final evaluation on ultrasound, and the mean thyroglobulin level decreased from 2.55 to 0.75, equating to a biochemical remission rate of 51%. And so importantly, there were no delayed complications associated with RFA after it was followed for 5 years. So in terms of future directions of using this technique, there's a lot of interest in treating primary thyroid carcinomas. And that's because the global incidence of PTC has been increasing over the past several decades, and particularly for micro PTCs, those that are less than a centimeter. It's been largely attributed to the detection and diagnosis of smaller tumors on ultrasound, mostly T1 tumors, so meaning less than 2 centimeters, but they are further subdivided into T1A, less than 1 centimeter, or T1B, between 1 and 2 centimeters. So these T1 tumors generally have a favorable prognosis and a low mortality rate. So for T1A tumors that don't have any evidence of extrathyroidal extension or lymph node metastasis or distant metastasis, conservative management such as active surveillance has been recommended, but consensus hasn't been reached on the specific protocol of how to surveil these patients. Thyroid lobectomy without a prophylactic central neck dissection has been touted as the preferred treatment for this subset of small tumors. And active surveillance is also recommended as a new conservative management for the T1B lesions that are between 1 to 2 centimeters. The problem with that is that there's not a lot of evidence on active surveillance of these particular tumors. So then you're subjecting patients to either a thyroid lobectomy for a small tumor or surveillance with, really no good information about the long-term outcomes of surveilling these type of tumors. So as such, RFA has been considered as an alternative to the active surveillance or thyroid lobectomy for these T1B lesions. A recent study just published this year sought to compare the clinical outcomes between thyroid lobectomy and RFA for the treatment of these T1B lesions. And they had a pretty long-term follow-up. So there were 1,500 patients who underwent surgery and 156 who chose RFA. And of those, after exclusion criteria, 91 patients who underwent RFA and 192 patients were treated with a thyroid lobectomy, and they were included in this study for comparison. So the RFA procedure was performed by 2 experienced U.S. physicians who had more than 5 years experience in performing RFA, and all RFA patients underwent a single session procedure. During the follow-up, there were no significant differences found in terms of local tumor progression, lymph node metastasis, recurrent tumor, or persistent tumor in the RFA treated group or the thyroid lobectomy group. Recurrence-free survival rates were noted at 1 and 4 years, and they were 98 and 95% in the RFA group and 97 and 96% in the thyroid lobectomy group, respectively. So this was an important study that revealed comparable results between thyroid lobectomy and RFA ablation of a T1 thyroid cancer. And it suggests that RFA may have a role in the management of these tumors. So as RFA and other thermal ablation techniques continue to expand in the United States, undoubtedly its role in the management of thyroid disease for both benign and malignant conditions will need to be re-examined and considered. There are several societies currently and organizations that have begun this process, including the American Thyroid Association, American Association of Endocrine Surgeons, American Head and Neck Society, and the Society of Interventional Radiologists. And the emerging experience from the United States is certainly going to contribute to the literature and to what we know about the treatment of these nodules. And hopefully will be consolidated with the international experience so that we can formulate some recommendation and guidelines for the safe implementation of this technique to our patients here in the United States. So thank you very much for your time, and I'm open to questions.
Thanks, Courtney. Are there any questions? I think maybe let me start it off. Obviously this is great and very exciting, and thank you for sharing all the data. 2 things. So number one, maybe just from an anatomical standpoint, when we're doing surgeries, we always worry about the recurrent laryngeal nerve or all the vasculature around it. And conceivably, if you're putting a very hot sort of radio frequency in that same zone, we worry about cautery getting too close to it. So how do you kind of reconcile that? And then I think secondly, maybe can you speak a little bit about, are there biomarkers that will help us identify the 3 cohorts, the patients that can just be watched, patients that should have some sort of radiofrequency ablation, and patients that should actually have surgery or something more that may help guide this? Because, any new technology has this worry of indication creep or overuse of the technology or lack of safety for patients. And so how are you thinking about it? And maybe speak a little bit about Yale and how do you think we'll implement that?
Yes. So to answer the first question, yes, of course, the most significant and complication after treatment of thyroid nodules surgically with radiation or with any type of percutaneous treatments is going to be injury to the recurrent laryngeal nerve. And so the best way to avoid that is to always identify where your needle tip is located. So that's why it's important to have real-time ultrasound guidance. The way you enter the nodule is less important as to identifying where that needle tip is and understanding that the ablation zone is going to be 3 to 5 millimeters beyond the tip of that lesion, right? So sometimes as surgeons, we always try and be better and best, right? But sometimes we have to take a foot off the pedal a bit and recognize that it's better to leave a smaller ablation area that may remain unablated as opposed to causing an injury. And again, greater than 50% reduction in volume is significant and as considered an effective treatment. So you can kind of come off of the border of that nodule and still be confident that at the 6 months time point, you're going to have at least that 50% reduction in volume. The most important thing is that the patients feel that their cosmetic or compressive symptoms have resolved. And also you can live to fight another day. And so appropriate patient education is important to let them know that sometimes it may require more than one ablation procedure. But again, it's like going in, I'm oversimplifying it, but it's similar to going in for a needle biopsy. Obviously a bit more complex and a bit more risk. But if you explain that thoroughly to the patient, I think that's the safest way to kind of stay safe, and also just keeping an eye on that needle tip, regardless of which way you enter the thyroid in the needle. And then your second question was talking about how can we always think about this too. So how do we know which thyroid cancers are going to be bad players as opposed to others? And I think that we just don't know, right? We think we have an idea, we'll see. And so that's why even with TI-RADS evaluation of thyroid ultrasound nodules, we'll say that if it's a TI-RADS 1 or 2 lesion, we treat that like it's benign. We don't have to worry about it. There's sometimes nodules that are less than a centimeter and they don't meet criteria for biopsy, but they have some characteristics like microcalcifications that put them up to like a TI-RADS 4 or 5. And what do we do with those? So sometimes some patients get those nodules biopsied and they turn out to be a papillary thyroid cancer. Other times people more strictly follow that criteria and they don't biopsy. They observe it, for another 3 to 6 months and rebiopsy and find that those nodules either have cancer or they do not. I just think that we just need more experience in looking at these nodules, observing them over time. You have to observe the natural history of them, but that means, without intervention really. And so that it's harder, I think, in the United States to not do something, both for the patient and for the provider. I've seen plenty of cases where I've taken out a 1 centimeter or less small thyroid cancer. Patient never had a recurrence. They're happy and fine. There've been cases where they've had to be on thyroid hormone. And then I've seen cases where a small nodule where I was planning to just do a lobectomy on because it was less than a centimeter, but then that patient presents with palpable or clinically relevant lateral neck disease, lymphadenopathy. So despite it being a small lesion, that had escaped to the lateral neck, and that patient needs a maximally invasive type of procedure. So I think we just need more time and experience and biomarkers to try and determine which ones are the bad players. Can we predict them in advance? And to date, I don't think we have a very good way of predicting that.
So that last study that you talked about was kind of a teaser. Do you think that it's going to be equivalent? Are you going to start offering the RFA for your patients with thyroid cancer? And the other part of that was that there were originally over 1,000 patients that were eligible for that study, but ended up comparing only about 190 some. And so is there really just a certain subset of thyroid cancers that could be addressed by RFA? Great talk. Thank you.
Thanks. So so very good questions. I think there's a lot that we don't know about how best to implement this, right? So I think the guidelines to date and the experience worldwide has largely been for benign thyroid nodules. So I think here in the US, we're becoming more comfortable with saying, okay, this is an appropriate potential intervention for benign thyroid nodules, right? And the literature supports that. What we don't have, and in the case of recurrences, or in patients who would not qualify for surgery because of other comorbidities, okay, yeah, here's another thing we can offer without just sitting and knowing that it's there and potentially gonna, cause some problems. So what we're trying to define and decide is this an effective treatment for these small PTCs, which is the question of the day. And if I had that answer, probably, I wouldn't be here right now, right? So I think it's going to have to involve a lot of education, a lot of experience on the part of the provider who's doing this intervention and comfort level. So, the best way to have an effective implementation of a new program is to really pick the ideal candidates, right? So you want lesions that are about 2 centimeters or so not too small so that you'll damage some surrounding healthy tissue, not too large that you'll have an ineffective outcome, but just the kind of perfect size. And you want to start with benign thyroid nodules so that you can get an effective improvement in symptoms. I think no matter what, even if I take out a 1 centimeter thyroid cancer by doing a lobectomy or even a total thyroidectomy, there's still no guarantee that that patient will never have a recurrence. We feel pretty strongly that they won't, But if there was, single cells in transit that just wasn't detected on ultrasound, eventually they're going to show themselves. And we see that time and time again. We see it when we do a thyroid lobectomy for a small thyroid cancer. And then those patients are under surveillance with you all as the primary care and endocrinologist. And 3, 6 months, 2 years down the line, okay, I see a little TIRADS 4 lesion in the remaining lobe. And then that turns into, okay, there's another focus of cancer, or there's a single lymph node here that looks concerning. So I think there's no way to guarantee that cancer will not come back. And I think patients have to understand that regardless of the intervention that you use. But to kind of more specifically answer your question, I think ultimately that would be my goal, to be able to treat these small PTCs, because I do think that it's overkill. So many years ago, when I first started here in 2013, we were doing a total thyroidectomy for a 1 centimeter thyroid cancer routinely. Total thyroidectomy, central neck dissection. And then, the American Association of Endocrine Surgeons and other organizations said, okay, is this overkill? Because we're putting so many patients on lifelong thyroid hormone supplementation for a cancer that's likely not going to kill them. It'll require some treatment, but it's not going to kill them. So then we kind of took a step back and revised our guidelines to say that a nodule up to 4 centimeters can be successfully treated with a thyroid lobectomy. Now, I can tell you from the surgeon side, many of us are reluctant to have a 4 centimeter thyroid nodule and just do a lobectomy on those nodules, because the normal dimensions of a thyroid gland or thyroid lobe is anywhere from 4 to 6 centimeters. So over 2/3 of the volume of that lobe is cancer. And I think that's, not appropriate in my personal opinion. 2 centimeters or less reasonable. But with that, there's still always the chance of recurrence. I do think that as we get more comfortable and effective in performing the RFA ablation for the benign, then there's this opportunity to kind of deal with. So the next phase will be like these indeterminate nodules, right? Dealing with the indeterminate nodules. And then ultimately, I think the goal would be for these very small lesions, ablating those lesions, and then following them over time, and making sure that we are continuing to follow those patients over time, so that if they do present with, locally advanced disease, that they also still are able to get effective treatment. And I think that's an important thing to note too, is that surgery is never off the table in the majority of cases, even if you have another intervention before then. Similar to patients who undergo radioactive iodine therapy for Graves' disease, makes the surgery tougher. But if that fails, those patients still can go on to surgery to treat their Graves' disease.
Dr. Gibson, are there any specific training guidelines in order to be able to do this procedure?
So that is being worked on by multiple medical societies, because the people who are performing these procedures come from very varied backgrounds. You have medical endocrinologists, you have interventional radiologists, and you have surgeons. And so there's a different experience that each one of us has undergone. And so we're trying to kind of coordinate and figure out what's the best way to get that experience, so to keep it safe for patients. So one, you definitely need to have experience and comfort in performing ultrasound. So that is universal. That needs to happen. You don't necessarily have to have a experience in performing fine needle aspiration biopsies. It's helpful, I think, to have that experience, but it's not required. But you are going to need some sort of formal training, either on cadaver models or an observership afterwards, in observing real live RFA ablation procedures. There's a surgeon in Brazil who, prior to the pandemic, was actually allowing people to come on site in Brazil and to observe and then perform RFA ablation in his patients. But again, that is not something that is going to be widely accepted in the United States, right? So we're going to be reduced to, one, getting ample experience in ultrasound performance, and then, experience with cadaver and observerships. I think that is going to be kind of the standard moving forward.
Great. Well, thank you, everyone. I think it's at the hour, and thanks, Dr. Gibson, again.
Thank you.